auditory canal, you have a very, very nice precision of the limitation of the penetration of the tumor into the internal auditory canal. So MRI is really important, and we perform an MRI before surgery. You see, when I started my department 20 years ago, we used the MKM as for microsurgery and navigation. You see all semi-sitting position when it's possible with a Retro-Sigmoid approach. You see the very old CUSA 20 years ago. And now we have developed in 2006 the first hybrid OR with an intraoperative MRI of 3 Tesla that we do not use for that kind of surgery, but the patient is still in this part of the hybrid. And you see the position of the patient, and we connect to the Pentero the curve navigation of BrainLab. So intraoperative monitoring, very important, the facial monitoring, the auditory monitoring, and you have this kind of electrodes going from the face and the ear of the patient. Alors, we have to be particularly aware during surgery. We have to be against the sigmoid sinus, against it. We have to be aware of the cranial nerve potential location, so we have to stimulate before surgery. You know that the nerve, the facial nerve, cannot be all the time perfectly frontward. We will perform a large central debulking, no coagulation, constant irrigation. It's the possibility that we have with the semi-sitting position. We perform a double forceps dissection of the arachnoid, and we'll be especially cautious when the dissection will approach the medial portion of the porus. I do not take systematically fats to close the opening of the internal auditory meatus. You see one of my very first patients, and here I should be able to. You see, it's an old movie. It's with the MKM. The MKM was a beautiful microscope. Unfortunately, they stopped to build it. And you see the principle of that surgery with navigation. Navigation can help you to debug very rapidly the tumor. And you see that we do not use the bipolar. It's a dissection with 2 forceps. You see here the brainstem. And we will retract. It's a surgery of 18 years of age. Sometimes still. The check with this bipolar stimulator, and some I dissect the nerve using the bipolar stimulator, the opening of the internal auditory meatus, the use of a hook to remove the bottom of the tumor from the internal meatus, and now removing the nerve, which is very thin, from the top of the tumor. So we check that stimulating the nerve at the brainstem is initiating an answer of the EMG, and when it's like that, we know that the surgery has been well carried out. So you see the preoperative status, and you see the postoperative status. In this case, it was a complete removal with the patient 3 months after surgery with a good facial nerve function. So, extent of resection. We perform an MRI at 2 months after surgery and annually to follow the patient. And in case of residue, we perform an MRI 6 months after surgery as well. You see the definition: total resection, no visible residue. near total when the residue is less than 5%, and most of the time it's a piece of capsule. Subtotal resection when the resection is above 80%, but there is a residue more than 5%, and partial resection below 80%. So on these 49 patients, we were able to perform a great gross total resection, near total resection in 75% of the patients. It's only large or giant vestibular schwannoma, and 5 cases were already operated before coming to us. And you see the rate of subtotal resection and the rate of partial resection with cases very strongly vascularized, as I will show you. So my message, we can perform a total resection, gross total resection, near total resection, 75%. But what's really important here, and I'm very proud of that, is that all of these cases have a good partial nerve function 3 months of 1 year after surgery, all of them. But 1 out of 3 have still a serviceable hearing when they have had a serviceable hearing before surgery. So 75% gross total resection, near total resection, for keeping to all the patients a good facial nerve function. Our worst facial outcome was this case, a patient of 70 years of age, you see. It was a cystic giant vestibular schwannoma. You see gross total resection, and you see the patient 6 months after surgery. He closed his eye, perfect closure, and you can appreciate what is it. Is it House-Bragman 2? I think. Is it House-Bragman 3? Okay, up to you. 2 patients had 2 surgeries with a preoperative House-Bragman grade 4. We were able to operate on this patient to perform a gross total resection, even if they were already operated twice, and to preserve the remaining of the facial nerve function. That means 6 months after surgery, the patient had still House-Bragman 4. The hemorrhagic cases. Look at this, a female of 30 years of age, a male 34, a male 23. That means that when you are with a large or giant vestibular schwannoma with a young guy or a young lady, you must be very, very cautious, and you should perform angio before surgery. I will never forget this case. It was a guy, 20 years of age, giant vestibular schwannoma, more than 40 millimeter, major hemorrhage during surgery, had to stop the surgery. The guy went to the intensive care unit, asked for an embolization. I operated on him again, and during the day after the first surgery, I was able to perform, at that time, I think, a near total resection. But this guy hasn't recurred since 20 years, or 18 years, actually. And you see the tumor here, importance of the vascularization, and here, who is after surgery. I think it's clearly House-Bragman 2, House-Bragman 1, without any more surgery, a young guy. Recurrence. Recurrence when you have left a piece of the tumor. 1% even total excision, 10% near total excision, subtotal excision 1 case, partial excision 2 cases, but we will speak about that later. So, radiosurgery is effective on vestibular schwannoma of less than 3 centimeters. Indeed, some papers report stabilization between 89% and 98%. So radiosurgery is an effective tool. But the side effects of radiosurgery, serviceable hearing loss depending on the authors, 30% from some people, 60% for others, trigeminal neuropathy, 3% of the cases, facial palsy for For my friend of Marseille, 0%. From some other people, 2%. Especially if there is less than 30 gray at the tumor margin. For large and giant vestibular schwannoma, no controversy, microsurgery. But what kind of microsurgery treatment? Do we do only intracapsular? Do we do two-stage resection? Do we combine microsurgery and radiosurgery? Some people, there are all kinds of reports in the literature. But because of loss of facial nerve function is a dramatic situation, and the face reanimation procedures are poorly effective, even if you perform a hypoglossophacial anastomosis, it's poorly effective. As the residue regrowth rate is low and the radiosurgery is effective, I think that the protocol has a great value. We have to keep good cranial function, good cranial nerve function, and total excision must come after. Here, the regrowth rate in case of total excision in the literature, less than 1%. In case of near total resection, around 10%. In case of subtotal resection, around 20%. That means in case of subtotal resection, 80% of the residue will not grow. And in case of partial resection, 53%. That means that one case in two, in a partial resection, won't regrow, won't grow after surgery. The few papers who have published their results with total resection or total excision, you see 96% total excision, 95% total excision, 100% frère Rebaud, 87, 100% total excision, and my group, 75%. The big difference is here in the results of the good facial nerve function. You can choose. Do you prefer total excision with a risk of 1 in 2 loss of facial nerve and less serviceable hearing? Here, 100% good facial nerve function after surgery. So the serviceable hearing, why? Even if you operate very cautiously, but you know that the anatomical reason, the facial nerve, the cochlear portion is glued to the vestibular portion, so it's really difficult to keep the serviceable hearing during surgery, but you can do it in 1 out of 3 cases, and there are also vascular reasons. I would like to conclude telling you that for vestibular schwannoma of more than 3 centimeters, our first goal is to preserve facial nerve function and cochlear nerve function using intraoperative neuromonitoring and navigation. And doing that, we are able to perform gross total or near total resection in 75% of the case, with so far a 100% good facial nerve function and only 1 case in 3 of serviceable hearing function after surgery. Thank you.
Hello, any questions from the floor?
I agree with you. It's the most difficult cases, and we are currently preparing a report only focusing on this cystic vestibular schwannoma. I think it's a question of experience and dissection. It's difficult. It's the worst case, and I think in some cases you will leave a piece of the capsule on the nerves. But as I show you, the recurrence is still low if you have a near total resection. But it's the most difficult case indeed.
The other extreme is again fibrous vascular atrophy. The moment you decompress, you start bleeding, fibrous tissue is there, and they decompress, how you manage those cases.
You see that now all the young patients